understand that your presidency was rather short. Can
Yes.
you explain that story a little bit?
Well, arguably, it was probably the most perfect presidency that the ASRA has ever experienced, because it lasted 3 minutes. Although there are reports that say I did stumble on one word during my acceptance resignation statement. And it had a lot to do with the fact that we were converting to a 2-year presidency. And that was simultaneous with me going into the executive officer track of the American Society of Anesthesiologists. At that time, they frowned on you holding offices in component societies while you were also in the executive branch of the ASA. So this was a perfect opportunity to make this transition for Dr. Horlacher to start the 2-year process.
Right. So what were some of the things that were going on in the society at that time?
Well, you know, the society has always been a society of leaders in regional anesthesia and pain medicine and obstetrical care, research, of course. And it was starting to change its governance. The obstetrical anesthesiologists were breaking away to form a bigger meeting at their SOAP Society, Society for Obstetrical Anesthesia and Perinatology. And so there were challenges there. We were looking to start the second meeting in the fall because pain medicine was becoming a very big part of our practice, and we didn't know how to get our arms around it because I mean, basically we were regional anesthesiologists doing blocks in the perioperative period, but largely intraoperatively. And there were few people like myself who were actually pain specialists. At the time I was a cancer pain specialist. I sort of morphed from regional anesthesia into cancer pain.
Okay.
And so we were trying to capture, if you will, the hearts and minds of those physicians who were developing the specialty of pain medicine. And that was the impetus for starting the fall meeting, devoted largely and almost entirely to pain of chronic nature. So I think over the years the experiment's been very successful, and they are two distinctly different meetings and that do have some strategic overlap. And the meetings back then, if you could get 800 people to a meeting, you were doing really well, and 1,000 was, you know, that was crack open the champagne, and now I heard there's about 1,200 here.
Right, yes.
So we were of course afraid that we would take an 800-member meeting and turn it into 2 400-member meetings with the fixed costs of running these meetings and having nothing more than a couple of pennies in the coffers, because we needed this money to run the society. You know, the board meetings were very animated. I mean, it was clear that we had factions, and I don't mean it in a hostile way, but there were factions on the board. There were people who were early pain specialists, and then there were people who were actually regionalists, true regionalists, and trying to decide how to allocate lecture time was always challenging, and and of course the parallel sessions helped because we didn't have to worry about so much time. We just simply go whichever one you wanted. There were 3 parallel sessions back then. But at the end of the day, the one thing we all had in common was that we all bled ASRA blood and wanted to see the society be the best it could be. It was at the time, and I still think it's probably the premier subspecialty society for ASA. I think it has the greatest researchers, scientists, innovators, It's not to take away from any of the other subspecialties, but people just seem to gravitate to regional anesthesia because of the neuropharmacology, the neurophysiology, the uncharted territory of putting needles in places where people dare not put them to see if it would improve patient safety and patient outcomes. Right. So there were a lot of, experimenters, that me being one of them, that did good things for people.
So it really does sound like the kind of a field that's just constantly evolving, constantly discovering new things.
Yes.
It's probably changed quite a bit.
Well, it's changed dramatically. I mean, we were needlers back then. I mean, everything was about, the tip of the needle being the mind's eye. I remember teaching that you had to really know what structures you were going through without physically being able to see those. And the blocks would take time. And the one real limitation to regional anesthesia was it was truly an art and a skill that you had to develop. It was almost like oil painting. You couldn't just take everyone, and give them a brush and say, okay, go there and do a masterpiece. There was a lot of skill involved in it, and a lot of patience in teaching residents. In regards to how it evolved, there was a point where I actually wrote an editorial because I was ASA newsletter editor for a while, and I wrote that the new regional technique was propofol LMA, and Jim Eisenach wrote a nice rebuttal to that. But it did raise everyone's consciousness to the level of, are we relevant? And it was becoming, blocks took time. Everyone was looking for efficiency. Right. If people, attempting a block and succeeding in a block are two different things. So success rates were really important. And surgeons, with the newer drugs, they were just saying, look, this is just taking too much time. We could just give these fast drugs, they're on and they're off, and the patient's on their way. So we had to redefine ourselves. And I think what saved regional anesthesia were the outcome studies that were starting to be done, and also the rise of ultrasound. Right. Now, early ultrasound, clearly you had to pretty much steal the ultrasound from the cardiac area and use it. We old timers who pretty much knew where the needle was every time we put it in, because we were anatomists pretty much. We had to be. In fact, every time I did a block, regardless of how many times I did it, I'm talking about the more complicated blocks that you do for cancer pain, I would have anatomy books tabbed, so I would just review them quickly to make sure that I knew the structures that I was going to go through, where the pitfalls were in terms of vascularity or CSF, things like that. I have to say that with all the societies that I've participated in, and I've been president of 3 separate anesthesia societies, that really, if you distilled me down to my professional essence, this society would be the society that I would call home. I started here. I never had aspirations to move out of ASRA, but ASA was a bigger calling, and it allowed me to promote pain medicine and regional anesthesia on the national stage. And in that respect, I think it benefited regional anesthesia too.